Important simplified. So we are going to continue with the anatomy of the female reproductive tract part 2 video. So let's move on to the anatomy of the internal genital organs. So the anatomy of internal genital organs consists of the vagina, the uterus, the fallopian tubes, as well as the ovary. So first, looking up to the vagina. So what is vagina? So vagina is a fibromuscular tube that extends from the vestibule to the uterine cervix. So starting from the vestibule up till the uterine cervix is going to be your vagina. Vestibule up till the uterine cervix is your vagina. So the attachment of the vagina of the cervix, the attachment of vagina to the cervix is going to be in its middle. Okay, therefore a gutter is going to be formed all around the cervix between it as well as the vagina, called as fornices. So there is a gutter that is formed all around the cervix between it and the vagina, and this is called as fornices. If you look at this figure, this is your vagina formed by vestibule here, vestibule and your up till the cervix. So up till the cervix, from the vestibule is your vagina, and then this is your uterus. This is your vagina, and this is your anterior fornix. See, it's a gutter. These are the two gutters that is formed. So this is your anterior fornix, this region is your anterior fornix, and this is going to be your posterior fornix. Okay, so again I'm reading this line. So it's a vagina is a fibromuscular tube starting from the vestibule to the uterine cervix. So the attachment of vagina to the cervix is going to be in the middle. Because it is attached in the middle, there is a gutter that is formed all around the cervix. So this gutter is going to be known as fornices. So there are two fornices, anterior as well as posterior fornix. So and lateral fornices. Okay, ureter as well as the urinary artery are in close proximity to the lateral fornices. So here the vagina, if you look at this figure carefully, the vagina is located to the cervix in its middle. Okay, it's located in the middle. So all around the cervix, okay, vagina is there is gutter like space all around the cervix. So just gutter like space formed by the vagina is known as, all around the cervix is known as fornices. So you have posterior fornix, anterior fornix and lateral fornix, and the uterine artery as well as the ureter is located very closely to the lateral fornices. Now the posterior attachment is at higher level, making the posterior fornix deep, and the anterior wall, the anterior wall of the vagina is therefore shorter than the posterior wall. That is why the anterior wall of the vagina is always shorter than the posterior wall. The opening at the vestibule is partially covered by hymen. So if you look at the vestibule, the opening at the vestibule is partially covered by hymen. The vaginal walls have rugae which allow stretching during parturition. So the vaginal walls will be having rugae which allow stretching during parturition. The axis of the vagina is going to be horizontal. So the axis of the vagina is horizontal. There are 3 sulci on the anterior vaginal wall. So what are these 3 sulci over the anterior vaginal wall? The submeatal sulcus, the bladder sulcus, and the transverse vaginal sulcus. Okay, so the 3 sulci on the anterior vaginal wall are submeatal sulcus, bladder sulcus, transverse vaginal sulcus. Okay, submeatal sulcus, bladder sulcus, and transverse vaginal sulcus. So again, this is your vagina. So if you look the ureter and the uterine artery. Okay, so these are your uterine artery as well as your ureter. Both are going to be related to this area. Okay, lateral fornices. Okay, both are related to the lateral fornices. Yeah, so uterine artery as well as the ureter are both related to lateral fornices. So if you look at the structure, so now let's look at vagina, the important points that we learned. First, it is a fibromuscular tube from the vestibule to the cervix. Okay, and the axis is horizontal, very important, not longitudinal. The axis is horizontal. It's a fibromuscular tube from vestibule to the cervix. It is closely applied to, anteriorly it's applied to the bladder as well as the urethra. Posteriorly it is applied to the posterior cul-de-sac, rectum, anal canal and perineal body, as well as anterior and posterior walls in opposition. So the vagina is a fibromuscular tube, axis horizontal, anteriorly is located to what? Posteriorly located to cul-de-sac, as well as the rectum, anal canal, perineal body and all. So now moving on to the structure of the vagina. So if you look at the vaginal wall is composed of 3 layers. So what are the 3 layers? So this is the structure of vagina from within to outwards. Okay, so from within to outwards there are 3 layers. First is the mucosa, the innermost layer, and then you have your muscle layer. After muscle layer you have your condensed endopelvic fascia. Very, very important. You have your condensed endopelvic fascia. Okay, so yeah, so mucosa, if you look, the mucosa is lined by stratified squamous epithelium and it also has a subepithelial connective tissue, whereas the muscle layer, it has 2 muscles, that is outer longitudinal and inner circular muscles, and then you have a condensed endopelvic fascia. So the mucosa, stratified squamous epithelium and subepithelial connective tissue, the muscle layer, that is outer longitudinal and inner circular, and a condensed endopelvic fascia. All these are the 3 main layers of vagina from inwards to outwards. This condensed endopelvic fascia will be learning in detail. So what are the clinical implications that we have studied so far? So the clinical implications of the anatomy of vagina are given. So first is the vaginal rugae. What is the importance of vaginal rugae? It has the evidence of estrogenization. So vaginal rugae is an evidence for estrogenization. Then the bladder sulcus. Bladder sulcus is for diagnosis of vaginal elongation of cervix. And then transverse vaginal sulcus. Transverse vaginal sulcus is for location of the bladder neck. And then the depth of the fornices, diagnosis of prolapse or elongation of the cervix. So what are the clinical implications? The clinical implications for anatomy of vagina are: first, the vaginal rugae is an evidence for estrogenization. Okay, because that is where estrogenization occurs. Vaginal rugae is an evidence for that. And bladder sulcus is for diagnosis of vaginal elongation of the cervix. So a very important diagnosis for vaginal elongation of the cervix is your bladder sulcus. Next, for location of bladder neck, you are going to have the transverse vaginal sulcus. and depth of the fornicis is for diagnosis of prolapse or elongation of the cervix. So now let's look at about uterus. So if you see, uterus is a pear-shaped hollow viscus located between the bladder as well as the rectum. It is divided into a cervix and uterine corpus. Okay, so this uterus is divided into a cervix and uterine corpus. Corpus means body. So there is uterine body and a cervix, and the dividing line being the internal os. Very important, the dividing line here between the uterine body, that is uterine corpus, and the cervix is going to be your internal os. Okay, so your internal os, and then first let's look at about the cervix. So the cervix is the lower part of the uterus. The cervix is the lower part of the uterus. It is continuous with the uterus. Okay, so the lower part of the uterus is your cervix. It is continuous with the uterus above and is attached to the vagina below. The attachment of the vagina divides the cervix into upper supravaginal cervix and a lower portio vaginalis. So the vagina attachment with the cervix is going to divide it into two regions, an upper supravaginal cervix and a lower portio vaginalis. It has an external os and an internal os and a cervical canal in between them. So the total length is around 2.5 to 3 centimeter. So the cervical length totally is 2.5 to 3. In this figure you can see the uterus and your cervix. So the uterus has a corpus which is body as well as a cervix. This is your cervix. So the dividing line, this is your dividing line. So the dividing line that is separating the uterus corpus and the cervix is the level of internal os. This is at the level of internal os. So if you look at the corpus dimension, the total is going to be around 5 centimeter. So this is 5 centimeter and the cervix length is going to be around half of the corpus, that is 2.5 centimeter. So 5 centimeter is uterine corpus and cervix is 2.5 centimeter. Now if you look at the cervix, the attachment of the vagina. So here you are having the attachment of the vagina. So the attachment of the vagina is going to be separating the cervix into two parts. The upper part is the supravaginal cervix and the lower part is the portio vaginalis cervix. So what is the upper part? It is the supravaginal cervix. Okay, supravaginal means wherever the vagina is attaching to the uterus, above that part, okay, above that region of cervix is your supravaginal cervix, whereas below that, okay, below the attachment of vagina is all the cervix part is known as portio vaginal cervix. Portio means what? It's a portion where the vagina is attached. The entire portion of cervix where the vagina is also attached, that is portio vaginalis cervix. Very easy, very simple. With the name itself you can understand. Supravaginal cervix means what? At the region where the vagina is attached to the cervix, above that part of cervix is known as supravaginal cervix, whereas the portion of vagina which is attached to the cervix, that part is known as portio vaginalis cervix. So uterine fundus is a part above the line of attachment of the fallopian tubes. The part of the cervix above the attachment of the vagina is supravaginal cervix, and below is your portiovaginalis cervix. So remember, the total length is half of uterine corpus, that is 2.5 centimeter. And generally in nullipara, the external os is going to be circular. After childbirth, it becomes like a transverse slit. So now let's look at the cervix in a box. So cervix constitutes of the lower part of the uterus. That's the first point. So it constitutes the lower part of the uterus. The total length is around 2.5 centimeter. It is divided into two parts by the attachment of the vagina to the cervix. It's divided into two parts, that is a supravaginal cervix and a portiovaginalis. It has three main structures, that is external os, internal os, endocervical canal between the two. So an external os, this is internal os, an external os, and an endocervical canal in between the two. Structure. If you look at the structure of the cervix, it's a fibromuscular wall. It has an endocervical canal lined by columnar epithelium, and ectocervix is lined by stratified squamous epithelium. So it's a fibromuscular wall. It has endocervical canal. So endocervical canal, endocervix, and an ectocervix. So the ectocervix is lined by stratified squamous epithelium, whereas endocervix is lined by columnar epithelium. Glands will secrete the mucus. Now let's look at the next part of uterus, which is the uterine corpus. So uterine corpus, the size and shape of the uterus changes with changes in the hormone levels. So the size changes with the hormone levels of the uterus. So the size of the uterus changes with the change in the hormone levels associated with puberty and pregnancy. The dimension of nulliparous uterus is given, that is around 5 centimeter. The uterine corpus is around 5 centimeter. The uterus is normally anteverted and anteflexed. So we will be looking at the image. What is anteverted? So what is anteverted and what is anteflexed? Okay, all this will be seen. So what are the normal uterus? It is anteverted and anteflexed. Now flexion, if you look at the flexion, is the angle between the uterus and the cervix. Okay. And version is the angle between the uterus and the vagina. Very, very simple. So the angle between the uterus and the vagina, okay, that is the cervix and the vagina, this angle is going to be your anteversion angle. Okay, version. Whereas the angle between the uterus and the cervix is going to be your flexion angle. So if you look at the structure, the uterine wall consists of three layers: inner endometrium, middle layer of myometrium, and outer serosa. So these are the three layers of the uterine wall. So inner endometrium, middle myometrium, that is having smooth muscles, outer serosa. So the endometrial cavity is continuous with that of the tube, cervix and vagina. The endometrium includes glands and stroma, is very sensitive to estrogen and progesterone, and undergoes changes during menstrual cycle and pregnancy. If you look at the myometrium, consists of three layers. Outer longitudinal fibers of myometrium are continuous with those of the tubes. Middle layer of interlacing fibers is important for uterine contraction and retraction. Very important. The middle layer of myometrium The middle layer of myometrium consists of interlacing fibers important for uterine contraction and relaxation. That's why it is also referred to as living ligature of uterus. The blood vessels pass through this layer and contraction of these fibers occlude the vessels and stops bleeding after parturition. So after parturition, so that is after delivery, what happens is this myometrium contracts. Because of this myometrium, this interlacing fibers of the middle layer of myometrium, interlacing fibers will contract, and because of muscle that in a myometrium contraction, the these interlacing fibers will be occluding the blood vessels. Because of blood vessels, postpartum hemorrhage will be reduced, and therefore it stops bleeding after parturition. That is why this interlacing fibers middle layer of myometrium is known as living ligature of uterus. The inner circular layer is thin and insignificant. The serosa or the peritoneum covering the uterus stops at the uterovesical junction anteriorly but extends down to form a cul-de-sac or pouch of Douglas posteriorly. So let's look at the histology of uterus. Among the histology of uterus, you have an endometrium, a specialized stroma, myometrium, and serosa. So endometrium, you have its uterus is lined by columnar epithelium. It has a cellular stroma and glands, uterine glands. It has a specialized stroma. It has a myometrium and 3 layers of myometrium, 3 layers, and the most important layer is the middle interlacing layer because it is the living ligature. I hope you guys now understand the meaning of living ligature. Inner circular, middle interlacing, and outer longitudinal. And serosa. Among serosa, peritoneum, incomplete anteriorly and complete posteriorly. So yeah, the histology of uterus: endometrium, specialized stroma, myometrium, 3 layers, living ligature, serosa, peritoneum, incomplete anteriorly and complete posteriorly. The cul-de-sac is the most dependent part of the pelvis, and therefore fluid or pus and blood will be collecting here to form abscess or hematocele. So if you see this diagram is given the parts of the fallopian tube. Interstitial part is within the uterine cornua, then you have your isthmus, then infundibular part and a ampullary part. So interstitial, isthmus, infundibular part. Okay, so infundibulum is a funnel shape and it ends in fibrae, and then the ampullary. Okay, so I'll be revising the structure of the fallopian tube. It has 3 layers: inner mucosa, outer serosa, in between muscularis layer. Structure of fallopian tube: mucosa, muscularis layer, you have outer longitudinal and inner circular. Mucosa is lined by ciliated columnar epithelium and an outer serosa. So the clinical implications of fallopian tubes are: the narrowest intramural part is very important. What is the importance about the narrow intramural part? The narrow intramural part has an early rupture of ectopic gestation. That is where the early rupture of ectopic gestation occur. Isthmus is the site for fertilization. Isthmo-ampullary junction. So therefore the site for tubal sterilization is isthmus. Isthmus is the site for tubal sterilization. Isthmus is the site for tubal sterilization. Now next, moving on to ovaries, very important structure. The tube and ovary together are referred to as adnexa. So what is adnexa? Many people think adnexa is something peritoneum or nearby. That's wrong. Adnexa is just a simple term which refers to both the fallopian tube plus the ovary. Both together, these two structures together are often referred to as adnexa. Very, very important. So tube plus ovary is nothing but adnexa. Adnexa. So the ovaries are the female gonads. So very important. What are the female gonads means? Ovaries are nothing but the female gonads. So the size of the ovaries vary with age, with the sex, steroid hormone levels and certain medications. The ovaries are located on either side of the uterus, close to the infundibulum of the tubes. So they are connected to the uterine cornua. They are connected to the uterine cornua by ovarian ligaments. They are connected to the uterine cornua by ovarian ligaments and to the broad ligament by mesoovarium. So two uterine cornuas are attached by ovarian ligament and with broad ligament by mesoovarium. So the hilum of the ovary is located along the mesoovarium and the vessels and nerves enter the ovary through the hilum. The ovarian vessels are carried in a fold of peritoneum called as the infundibulopelvic ligaments from the lateral pelvic wall to the ovary. Vestigial remnants of the cephalic and caudal ends of the Wolffian structures persist as hypoophoron, paraophoron that can occasionally enlarge and form cysts. Very, very important. So the vestigial remnants of the vestigial remnants. So the vestigial remnants of the cephalic and caudal ends of the Wolffian structures, if they persist. So persistence of Wolffian structures, that is the vestigial remnants of the Wolffian structures, are nothing but referred to as hypooophorone and paraoophorone. Next, moving on to the structure. So the structure, the ovary is divided into an outer cortex and an inner medulla. So the cortex, if you look at the cortex contains specialized stroma and follicles. The cortex contains specialized stroma as well as follicles and is responsible for the important functions of ovulation and steroid hormone production. So very important for ovulation and steroid hormone production. So the ovarian medulla is the stroma of the ovary and is highly vascular. It is developed from the embryonic mesenchyme and contains blood vessels, lymphatics and nerves. So if you look at the attachments of the ovary, infundibulopelvic ligament over here. So the infundibulopelvic ligament over here attaches the ovary to the lateral pelvic wall, whereas mesoovarium lies between the ovary as well as the broad ligament. So this is your broad ligament, this is your mesoovarium. So ovary in general, the size is 3 cross 2 cross 1, 3 to 1, 3 cross 2 centimeter, and the mesoovarium which is a part of mesentery, is in the related to the posterior surface of broad ligament, and then the ovarian ligament is attached to the uterine cornua. The infundibular ligament is attached to the lateral pelvic wall. So moving on to the structure of the ovary, it has an outer cortex and a inner medulla. The cortex is lined by cuboidal surface epithelium. It has a specialized stroma as well as specialized follicles, both stroma and follicles. Medulla, it's a fibromuscular tissue with blood vessels. So let's look at the clinical implications regarding ovary. So the ovarian cortex contains primordial follicles. Very important. Primordial follicles are present in ovarian cortex. Hence, as much of cortex as possible should be preserved during wedge resection of the ovary. Okay, it should be preserved. It should be preserved during wedge resection of the ovary. Next, clamping of the infundibulopelvic ligament. So clamping of the infundibulopelvic ligament compromises blood supply to the ovary. Okay, clamping. So clamping the infundibulopelvic ligament. So when you are clamping the infundibulopelvic ligament, it compromises the blood supply of the ovary. Due to proximity of the ovary to the tube, infection and malignancy spread from one structure to another very early. This is a beautiful cut section of ovary revealing the cortex and the medulla, and the Graafian follicles are located in the cortex. So if you see, this yellow color it's the outer medulla, outer cortex and a inner medulla. Okay, so the cortex has stroma, okay, in yellow color, as well as these structures which are the follicles. And if you see, you have a Graafian follicle here, the biggest dominant follicle, that is the Graafian follicle, big one. And this is the corpus luteum in yellow color. This is the hilum of the ovary. This is the hilum of the ovary, and these are the ovarian vessels. So from in the hilum of ovary, you can see the ovarian vessels. So now let's move on to endopelvic fascia. I already told condensed endopelvic fascia. So what is this endopelvic fascia? This endopelvic fascia is a facial covering or sheath around the pelvic viscera, blood vessels and other structures that enter and exit the peritoneal cavity. It is divided into parietal layer that forms the sheath of the pelvis muscles, as well as the visceral layer that ensheaths the pelvic viscera. So the space between the peritoneum and the pelvic is going to be filled with a loose pelvic cellular tissue. The pelvic cellular tissue is continuous with the tissue of the perinephric space, the tissue above the levator ani and obturator internus, and extends along the sheets of vessels and other structures. Fluid or pus collected in cellular tissue can spread through the spleen and cause infection. So now let's study about the ligaments. So moving on to the ligaments, the endopelvic fascia condenses in some areas to form ligaments. Okay, so this endopelvic fascia condenses in some areas to form ligaments that will support the uterus as well as the other pelvic structures. So basically all these ligaments are nothing but condensation of endopelvic fascia. So what are these ligaments of uterus and cervix? This is a very, very important short note. Write a short note on ligaments of the uterus and cervix. So first is, we will be studying about the cardinal ligaments, and then we'll be studying about the pubocervical ligaments, and then we'll be studying about the uterosacral ligaments, and then the round ligaments, the broad ligaments, the ovarian ligaments, and the infundibulopelvic ligaments. So totally we are studying cardinal ligaments, pubocervical ligaments, uterosacral ligaments, round ligaments, broad ligaments, ovarian ligaments, and infundibulopelvic ligaments. All these 7 ligaments are very, very important. So the first one is the cardinal ligaments, the pubocervical ligaments, the uterosacral ligaments, the round ligaments, the broad ligaments, the ovarian ligaments, and the infundibulopelvic ligaments. So first let's look at the cardinal, or otherwise known as, very important, cardinal or McEnroth ligaments. So what is these cardinal or otherwise known as McEnroth ligaments? So these McEnroth ligaments extend from the lower part of the uterus and the supravaginal cervix and the lateral vaginal cervix and the lateral vaginal fornix to the lateral pelvic wall. Okay, so this McEnroth ligament is a cardinal ligament arising from the lower part of the uterus, and the loose cellular tissue in this area is referred to as parametrium. Okay, so the loose cellular tissue is referred to as parametrium. The ureter, before entering the bladder, transverses this ligament, is encased in a facial sheath called as ureteric tunnel, which lies 2 cm lateral to the cervix. The uterine artery crosses to the uterus above the ureter at this point. The descending cervical branch of the uterine artery courses through this ligament. The lymphatics from the upper vaginal cervix also course through the ligament, and some drain into the parametrial node. Frankenhauser plexus. We have a plexus known as Frankenhauser plexus, which consists of sympathetic ganglia and nerves, also will be extending to the parametrium. So the area which is the loose cellular area is referred to as parametrium. If you see in this diagram, this is the uterus, this is the ovary, and this is the ovarian ligament. This is your ovarian ligament, and over here you have your infundibulopelvic ligament. This structure is your broad ligament, and this structure is your round ligament. So round ligament, infundibulopelvic ligament, ovarian ligament, and broad ligament. Spread of infection and malignancy into the parametrium and the cardinal ligaments occurs via the lymphatics. Parametrial extension of malignancy is important staging. Parametrial extension of malignancy is very important staging in cervical cancer. So once again I'll briefly tell you about the contents of cardinal ligaments, that is McEnroth ligaments, McEnroth ligament, and the parametrium. So first one is the ureteric canal, very, very important one, which is the ureteric canal. And then you have a descending cervical artery, lymphatics and lymph nodes, parametric lymph node, and Frankenhauser plexus, very important, Frankenhauser plexus. So ureteric canal, parametric lymph nodes and other lymph nodes, and Frankenhauser plexus are the contents of parametrium and the McEnroth ligament. So if you look at this figure, these are the structures of the cardinal ligament or the McEnroth ligament. You have a descending cervical branch of the uterine artery. Okay, so this is the uterine artery. This one over here is your uterine artery, and this branch, okay, this branch that you are having, this is the descending cervical branch. Okay, this branch over here is your descending cervical branch. Okay, so this descending cervical artery is a branch of your uterine artery, just branch here. Just descending cervical artery is a branch of your uterine artery. That is a structure in the cardinal ligament. And then you have the ureter over here, this area. So this area, this region, this is your ureter. And then you have your ureteric tunnel. So the tunnel in which, if you see, there is a tunnel over here. Okay, there is a tunnel over here. Within this tunnel only your ureter is entering. So this tunnel is otherwise known as ureteric tunnel. And then you have your ureter in the ureteric tunnel, and lymph nodes are there. So these are your lymph nodes. And then you have Frankenhauser plexus, very important. This is your Frankenhauser plexus. So again I am going to revise. Let's revise over the structures of the cardinal ligament. So just beautiful, just one is your cardinal ligament. Okay, this ligament over here is your cardinal ligament, otherwise known as McEnroth's ligament. So in this ligament, if you see, in this ligament, what are the structures of this ligament? You have your uterine artery coming from above, and you are having a descending cervical branch, of the uterine artery, first content. And then you have a ureter within the ureteric tunnel, that is the second content, ureter within the ureteric canal. And then you have lymph nodes, and then you have a very, very important nerve plexus. That plexus is known as Frankenhauser plexus. Frankenhauser plexus. So again, the contents of the ureteric canal are ureteric canal and ureter plus ureter. And then your descending cervical artery, which is a branch of uterine artery, lymphatics and lymph nodes, and Frankenhauser plexus. Finished. Next, moving on to the second important ligament, which is your pubocervical ligament. So pubocervical ligament is a condensation of pubovesicular vesicocervical fascia. Condensation of pubovesicocervical fascia passes from the anterolateral aspect of the cervix to the posterior surface of the pubic bone. Some fibers extend from the bladder and the pubis and form the bladder pillars. Pubocervical ligaments merge posterolaterally with the cardinal ligaments. Number 3 is your uterosacral ligaments. Okay, your uterosacral ligaments. So these ligaments extend from the posterior part of the supravaginal cervix, okay, to the sacrum, and they lie on either side of the rectosigmoid. Anterolaterally they match with cardinal ligaments. Frankenhauser plexus of nerves is located mainly on these ligaments. So this Frankenhauser plexus of nerves is mainly located at these uterosacral ligaments. So the 3 ligaments together are referred to as triradiate ligaments. Very, very important MCQ question. So what do you mean by triradiate ligament? So I am writing here clearly. So all the first 3 ligaments, okay, I am writing over here. What do you mean by triradiate? Triradiate ligaments. So triradiate ligaments consist of first your cardinal ligaments, and then your pubocervical ligament, and number 3 is your uterosacral ligament. So triradiate ligament consists of these 3 important ligaments: cardinal ligament, pubocervical ligament, uterosacral ligament. Cardinal ligament, pubocervical ligament, and uterosacral ligament. So all these 3 ligaments together are known as triradiate ligaments. Next, moving on to the 4th ligament, which are your round ligaments. Very, very important one. Okay, round ligaments. So these are vestiges of the gubernaculums okay, vestiges of gubernaculums and are made up of a fibromuscular tissue. They extend laterally from the uterine cornua, okay, from the uterine cornua extraperitoneally to enter the inguinal canal and finally merge with the skin and connective tissue of the mons pubis and labia majora. So the ligament consists of a blood vessel arising from the uterine or ovarian artery and should be ligated during the surgery. So the ligament consists of a blood vessel arising from uterine or ovarian artery and should be ligated during surgery. So these are the ligaments attached to the lower uterus and the cervix. So the ligaments attached to lower uterus as well as the cervix, all these three ligaments, cardinal ligament, pubocervical ligament and uterosacral ligament, all these three ligaments, okay, all these three ligaments are attached to the lower uterus as well as the cervix, and that is why all these three together are known as triradiate ligaments. So triradiate ligaments consist of cardinal, pubocervical, uterosacral. If you look at this figure, so this is your sacrum, this is your rectum, this is your vagina, this is your bladder, okay, your three holes, rectum, vagina and bladder with urethra. So if you look at, this is your mons pubis, so this is your pubis and this is your sacrum, okay, your pubis bone. So from the pubis, okay, surrounding the vesico stands for urethra or bladder, okay. So from the pubis to the attaching to the urethra or bladder and then to the cervix, okay, and then to the cervix is known as your pubovesicocervical ligament. So pubovesicocervical ligament, so is this one, pubovesicocervical ligament. This is pubovesicocervical ligament. And now the cardinal ligaments, okay. So the cardinal ligaments, this is your cardinal ligaments on either side of the vagina. So this is your cardinal ligament, and then from this vagina, okay, so from this vagina from the uterus to the sacrum, okay, from the uterus to the sacrum is your uterosacral ligament. So from your pubis to the bladder and then to the cervix is your pubovesicocervical ligament, and then your cardinal ligaments, which is Meckenroth ligament, is on either side of the uterus, and then your uterosacral ligament is there. These are your triradiate ligaments. And then we finish the round ligament, and the round ligament contains uterine or ovarian artery, okay, and this will be ligated usually during the surgery. Next, moving on to the broad ligament. So broad ligaments, the peritoneum on the anterior and the posterior surfaces of the uterus spreads out laterally towards the pelvic wall to form a broad ligament. Okay, so the peritoneum is going to be lateral towards the pelvic wall to form the broad ligament. So between the two layers of the peritoneum is the pelvic cellular tissue containing ureter and plexus formed by the anastomosis of the uterine and the ovarian vessels. The round ligaments, okay, the tubes and the ovarian ligaments, all these things, okay, the round ligaments, the tubes and the ovarian ligaments are all going to be covered by peritoneum of the broad ligament, okay. So the round ligaments, the tubes, the fallopian tubes and the ovarian ligaments all are going to be covered by this peritoneum of the broad ligament and are contained in its upper part. Very important. The broad ligament contains our round ligaments, tubes and ovarian ligament. Next, moving on to the ovarian ligaments. They pass from the medial pole of the ovaries to the uterine cornua posterior to the attachment of the tubes. And then you have your infundibulopelvic ligaments. So infundibulopelvic ligaments are lateral extensions of the broad ligaments between the ovary as well as the pelvic wall. They contain the ovarian vessels. Okay. Extension from the broad ligament is your infundibulopelvic ligament containing your ovarian vessels. So I'll revise this figure for you. So you have your round ligaments over here, and then you have your ovarian ligament, then you have your infundibulopelvic ligament, and this is your broad ligament. So what are the clinical implications of both the cardinal as well as the uterosacral ligament? So if you look at the clinical implications, first of both the cardinal and uterosacral ligament, first congenital or acquired weakening of the cardinal and uterosacral ligament causes descent of the uterine cervix as well as the uterus, leading to pelvic organ prolapse. So if suppose these ligaments, okay, if there is weakening of these cardinal or uterosacral ligaments, there is going to be descent of the uterus or the cervix, leading to pelvic organ prolapse. While clamping the cardinal ligament, okay, while clamping the cardinal ligament during, say, hysterectomy, while clamping the cardinal ligament, care must be taken to avoid the ureter in the ureteric canal. So because the cardinal ligament consists of ureter in the ureteric canal, care must be taken to avoid injury to the ureter and the ureteric canal during clamping the cardinal ligament during hysterectomy. Now next, moving on to a very interesting topic, that is your pelvic floor. Okay, so the pelvic floor, the pelvic organs are going to be supported in the upright position by a fibromuscular floor that includes the levator ani, coccygeus muscle, external anal sphincter, urethral sphincter, and deep perineal muscles. So what is pelvic floor? Pelvic floor alone can be a short note. So write a short note about pelvic floor. The pelvic floor, all the pelvic organs is supported by a fibromuscular fold, that is your pelvic floor. And what are the muscles consisting of pelvic floor? First is your levator ani, your coccygeus muscle, your external anal sphincter, your urethral sphincter, and your deep perineal muscles. So first is your levator ani, and then your coccygeus muscle, and then your external anal sphincter, and then your urethral sphincter. Two sphincters are there, external anal sphincter, urethral sphincter, and then your fifth one is your deep perineal muscles. Okay, so levator ani, coccygeus, external anal sphincter, urethral sphincter, and deep perineal muscles will be forming your pelvic floor. Now another important short note, which is your pelvic diaphragm. This is also another important short note. So write a short note on pelvic diaphragm. Pelvic diaphragm consists of levator ani muscle covered by your pelvic fascia. So your levator ani muscle covered by your pelvic fascia is going to be your pelvic diaphragm. So this muscle covers the space from the pubic bone to the coccyx and from one pelvic side wall to another, forming a funnel shaped support. The muscle has three components basically. Okay, what are the three components of this levator ani muscle? So this muscle has three components: the puborectalis, the pubococcygeus, and iliococcygeus. Puborectalis, pubococcygeus, and iliococcygeus. Fibers of the puborectalis are going to be inserted into the vagina, known as pubovaginalis. So some fibers of puborectalis are inserted into the vagina, known as pubovaginalis. So the coccygeus, formerly called as ischiococcygeus, extends from the ischial spine to the coccyx. Okay, and it's not a part of levator ani. So what is basically pelvic diaphragm? The pelvic diaphragm is basically your levator ani muscle along with the pelvic fascia. Okay, so it's very simple. Levator ani muscle covered with pelvic fascia is your pelvic diaphragm. It consists of what muscles? It consists of three muscles, that is your pubococcygeus muscle, pubococcygeus muscle, puborectalis muscle, and ilio. Okay, remember, not ischio, it is ilio. Iliococcygeus muscle. Pubococcygeus, puborectalis, iliococcygeus. So the components of levator ani, again I am revising guys for you. It's your puborectalis, pubococcygeus and iliococcygeus. Now the muscle fibers of the levator ani muscles, all these muscle fibers, okay, from your levator ani muscles will be arising from a structure known as arcus tendinous fascia pelvis or white line. Okay, what is it known as? All the muscles, okay, remember all the muscles of the levator ani, all the muscles of the levator ani muscles will be arising from a common line known as a white line, and white line is otherwise known as arcus tendinous pelvis fascia pelvis. Arcus tendinous fascia pelvis, otherwise known as white line. So all the muscle fibers of the levator ani muscle will be arising from a common line known as arcus tendinous fascia pelvis or the white line, which is thickening of the fascia covering the obturator internus muscle and extends from the pubic bone to the ischial spine. So the fibers of the levator ani will pass backwards and medially and fuse in the midline, forming the levator plate. So all these fibers of the levator ani, okay, all these fibers will be passing backward and medially to fuse in the midline, okay, that is the white line or arcus tendinous fascia pelvis, and will be forming the something known as the levator plate. So urogenital hiatus. So urogenital hiatus is a space between the levator ani muscles, okay. The urethra, vagina and the anal canal are enclosed in this hiatus. So the fibers of the puborectalis arise from the pubic bone from a sling around the vagina and the rectum and is inserted into the perineal body, rectal wall and anococcygeal raphe. The medial and anterior fibers that cross the lateral vaginal wall between the middle and the lower third are inserted into the vaginal wall, and the perineal body is referred to as pubovaginals. Okay, some fibers decussate behind the urethra, pubourethralis. All of this is not very much important. Just remember this diagram. This is your pubis. This is the obturator fascia and the obturator internus muscle over here. So your obturator fascia and obturator internus muscle is here, and this common white line from which the levator ani muscles all will be inserting is your arcus tendinous. Very very important. Arcus tendinous, otherwise known as your white line. Okay, so arcus tendinous or white line is where all the levator ani muscle fibers will be arising from. And then this is your vagina. See, arcus tendinous fascia pelvis is shown here. It extends from the pubic bone to the ischial spine. Okay, to the ischial spine. And if you see, look at this diagram. These are the components of the levator ani muscles. Your puborectalis, your pubococcygeus and your iliococcygeus. See, this is your urethra, your vagina. This is your pubic bone. Okay, so this muscle over here, this part is your pubovaginalis. Puborectalis part, from the puborectalis part, some fibers to the vagina is known as pubovaginalis. And this is your common this is the line from which all the muscle fibers of levator ani arise from. That is your arcus tendinous fascia pelvis. This is your arcus tendinous fascia pelvis, the green line. And this is your iliococcygeus. Okay, your iliococcygeus, your puborectalis, some fibers to the vagina is pubovaginalis, puborectalis, iliococcygeus, and then you will be having your pubococcygeus also. Remember just arcus tendinous pelvis fascia pelvis. The pubococcygeus muscle fibers also arise from the posterior surface of the pubis and are inserted into the rectum, anococcygeal raphe and the coccyx. The ischio-coccygeus is not a part, so not important. So the levator ani muscle has a resting tone that keeps the pelvic floor closed and prevents herniation of the uterus and the cervix. This is very important. Why is this levator ani muscle very important? Is it prevents herniation, prevents herniation, okay, of the uterus and the cervix. So when the muscle is damaged, as happens after a multiple vaginal deliveries, the resting tone is lost and herniation of pelvic organ prolapse results. Now moving on to the clinical implications. So what are the clinical implications? So first is the resting tone of the fibers of the levator ani provides support for the pelvis viscera. That's the support for the pelvis viscera is the first clinical implication. And they help maintaining the urinary and the rectal incontinence also. Maintain the urinary as well as the rectal continence during increase in intra-abdominal pressure. So whenever there is increase in intra-abdominal pressure, the urinary and rectal continence is maintained by your pelvic floor. Next, moving to a very important short note, supports of uterus. Very important short note. Write a short note on the supports of uterus is a question. So supports of uterus is going to be supported by ligaments and pelvic floor, okay, both the components. So uterus is basically supported by two structures, your ligaments plus your pelvic floor, okay, both ligaments plus your pelvic floor. So the round as well as the broad ligaments are going to be weak ligaments. These are weak, okay, these are generally weak ligaments, but the cardinal and the uterosacral ligaments support the cervix as well as the upper vagina. So your round and the broad ligaments of the uterus are going to be weak ligaments, whereas your cardinal ligament, your McEnroe ligament as well as your uterosacral ligament, these ligaments will be supporting the cervix and the upper vagina properly. So stretching of these ligaments with childbirth or any postmenopausal atrophy leads to prolapse of the cervix or the vaginal apex. Now the pelvic floor mainly containing of the levator ani muscle. The levator ani muscle is the main structure that supports the uterus and holds it in the position. So the main structure supporting the uterus is your levator ani muscle. So weakening or loss of tone of this muscle plays a major role in the pathogenesis of prolapse. So weakening of the tone, okay, or loss of tone of this levator ani muscle will be leading to the pathogenesis of prolapse of uterus. Now let's look at the supports of the vagina. Vaginal supports also hold the bladder, rectum and urethra in their position, okay. So the vaginal supports are divided into level 1, level 2 and level 3, okay, D and C level. So weakening of these supports cause prolapse of the cervix or vaginal apex, leading cystocele, rectocele and urethrocoele, okay. So weakening of these supports cause prolapse of cervix or vagina apex, cystocele, rectocele and urethrocoele. Now pelvic organ prolapse, okay, pelvic organ prolapse. So the level 1, okay, if you look at the level 1, so if you look at the level 1 supports are going to be uterosacral and cardinal ligaments, and support the upper vagina as well as the cervix. The lateral vagina and the endopelvic fascia around the middle third of the vagina are attached to the arcus tendinous fascia pelvis, okay. So the lateral vagina as well as the endopelvic fascia will be attached to this arcus tendinous fascia pelvis. So the lateral vaginal sulcus represents this line of attachment that runs from the pubic bone to the ischial spine on either side. This forms the lateral support at level 2. So level 2 lateral support is your endopelvic fascia attached to your arcus tendinous fascia pelvis, and so posteriorly there is a condensation of the endopelvic fascia on the levator ani that extends from the arcus tendineus fascia pelvis to the perineal body and is known as arcus tendineus fascia rectovaginalis. Arcus tendineus fascia rectovaginalis. The attachment of the posterior vaginal muscularis to just forms the posterior support at level 2. The perineal body, superficial and deep perineal muscles, and the perineal membrane. Okay, all of this, the perineal body, your superficial and the deep perineal muscles, as well as your perineal membrane, all of this support the lower third of the vagina and constitute to level 3 supports. Okay, so level 1 support, level 2 support, and level 3 support. So level 1 support is your cardinal ligament plus your uterosacral ligament, whereas level 2 is your endopelvic fascia, your arcus tendineus fascia, endopelvic fascia, your arcus tendineus, and your level 3 is going to be all your perineum, superficial perineal muscles, your deep perineal muscles, okay, and your perineal body. So these are the 3 levels of supports of vagina. So clinical implications of the supports of vagina are the cardinal as well as the uterosacral ligaments will be the first cause or pathogenesis of prolapse, and surgical correction of prolapse is going to be done in just ligaments. So cardinal and uterosacral ligaments is the pathogenesis of prolapse, and then you have your levator ani being the pathogenesis of prolapse, and then your cardinal ligaments for dissection during radial hysterectomy. Okay, so yeah, pathogenesis of prolapse, levator ani, cardinal and uterosacral ligaments, and also playing a role in the dissection during radical hysterectomy. So now let's look about pelvic ureters. The ureters are located retroperitoneally and run from renal pelvis to the urinary bladder. Pelvic ureter topics is not a very much important topic. We can just move on. You can just go through this course of pelvic ureters alone. Yeah, you have your rectum, you have your vagina, you have your bladder, and you have the course of the ureter over here. So the ureter enters the pelvis. Crossing the bifurcation of the common iliac artery. So the ureter enters the pelvis crossing the bifurcation of the common iliac artery. So this one is the bifurcation of the common iliac artery, and then you have your uterine artery over here. The uterine artery crosses over the ureter. So just see here, this area, the uterine artery crosses over the ureter, and the ureter lies close to the anterior vaginal wall also. So the ureter lies close to the anterior vaginal wall. So this is your common iliac artery. Your ovarian artery crosses the ureter also. So both the uterine artery as well as the ovarian artery crosses the ureter. This is your cardinal ligament over here, where the ureter lies in the ureteric canal. So you have your ureteric canal. In the cardinal ligament, the ureter lies in the ureteric canal of the cardinal ligament. So here this beautiful diagram, the ureter lies in the ureteric canal of the cardinal ligament. This is the course of your pelvic ureters. So this is your uterine artery related to your ureter. Okay, this is your uterine artery that is related to your ureter. The ureter crosses under the uterine artery. It is a water under the bridge. So because this ureter crosses under the uterine artery, okay, it is like water under the bridge. So because this ureter crosses under the uterine artery, it is like a water under the bridge. So the clinical implications are: the ureter lies in close association with several pelvic structures and is therefore susceptible to injury during a variety of pelvic surgical procedures. It is important to know the points at which there is a close proximity so that care can be taken to avoid such injury and formation of a fistula. Its close proximity to the ovarian and uterine vessels makes it prone to injury during common gynecological procedures such as hysterectomy and oophorectomy. So your course of pelvic ureters is given in a box. First, the pelvic ureters crosses the common iliac artery at bifurcation. Common iliac artery bifurcation. It lies medial to the ovarian vessels that cross over it soon after. So this is your ovarian vessels. So it lies medial to the ovarian vessels. Okay, it lies medial to the ovarian vessels that will be crossing the ovarian. Yeah, that will be crossing over it after. It lie attached to the posterior peritoneum. So ureter lies attached to the posterior peritoneum. It reaches a level of the uterosacral ligaments. It turns forward at the ischial spine. It ends the base of the broad ligaments. It crosses under the uterine vessels. So it's known as water under the bridge. It crosses under the uterine vessels. It enters the ureteric canal in the cardinal ligament. It runs forward to enter into the bladder, and it lies close to the anterior vaginal wall. So this is your course of pelvic ureter in a brief. So ovarian artery crosses the ureter, and the ureter enters the pelvis crossing at the bifurcation of the common iliac artery, and uterine artery crosses the ureter, that is ureter is under the uterine artery. The ureter lies close to the anterior vaginal wall, and the ureter lies in the ureteric canal of the cardinal ligament. So again I am revising the course. The course of pelvic ureters: first it crosses the common iliac at bifurcation. It lies medial to the ovarian vessels that cross over it soon after. It lies attached to the posterior peritoneum. It reaches the level of the uterosacral ligaments. It turns forwards at the ischial spine. It enters the base of the broad ligaments. It crosses the uterine vessels, and it enters the ureteric canal in the cardinal ligament. It runs forwards to enter into the bladder and lies close to the anterior vaginal wall. Points at which the ureter is prone to injury is your pelvic brim, where clamping infundibulopelvic ligaments, and bifurcation of common iliac when you are doing internal iliac artery ligation, and broad ligament when you are doing your uterine artery ligation, your cardinal ligament when dissection of the ureteric canal is done and clamping of the cardinal ligament is done, and the upper vagina clamping the vaginal angle, and devascularization, that is all through the course of the pelvis. So if you look at this figure, beautiful diagram closely, you can look at the relations of the pelvic ureter. So first it crosses the bifurcation of the common iliac artery, and then crosses under the uterine artery to enter into the ureteric canal. So this is your common iliac artery where there is bifurcation of the common iliac artery, and this is your ovarian artery. Okay, all of the ovarian artery crosses over the ureter, and the ureter also enters from the common at the bifurcation of the common iliac artery, and yeah, it's going to be, and then it will be entering into the urinary bladder. Okay, and then it is going to be passing under the uterine artery. So now moving on to the next. So just remember that the space between the bladder and the pubic symphysis is your space of Retzius. Space of Retzius. So space of Retzius, Retzius is the space between the bladder and the pubic symphysis. So the clinical implications of urinary bladder and urethra are: bladder is closely applied to the uterus, and injury while pushing the bladder down, okay, and adhesion due to previous surgery will occur. And then you have your space of Retzius. Space of Retzius is an approach to the surgical correction of stress incontinence. So let's look at the branches of internal iliac artery. So you have your aorta over here, and then this is your common iliac artery. This common iliac artery bifurcates into, this is your common iliac artery. Common iliac artery bifurcates into an external iliac artery and an internal iliac artery. So internal iliac artery has two divisions, your posterior division and your anterior division. Okay, so internal iliac artery has two divisions, your posterior division, anterior division. So anterior division, what are the arteries in the anterior division? So your arteries are going to be your superior vesical artery, and then your obturator artery, superior vesical artery, your obturator artery, and then the uterine artery, and then your vaginal artery, and then your middle rectal artery and inferior vesical artery, inferior gluteal artery and internal pudendal artery. All these are branches of internal iliac artery. What are the branches? Your superior vesical artery, your obturator artery, your vaginal artery, your uterine artery, your middle rectal artery, your inferior vesical artery, your inferior gluteal artery, and your internal pudendal artery. All these are branches of the internal iliac artery. So branches of the uterine artery and its anastomosis with branches of ovarian artery. If you see, this is a beautiful diagram. This is your ovarian artery, and you have arcuate artery, which is a branch of the uterine artery. So uterine artery from below. So the uterine artery, the branches are going to be mainly arcuate artery, and this arcuate artery and ovarian artery will be doing anastomosis. So the arcuate arteries gives off several branches known as radial arteries. So these radial arteries are several branches of this arcuate artery. So next important one is this is your Alcock canal, course of the pudendal artery, your Alcock canal. Remember this canal, Alcock canal, where the pudendal vessels will be running through this Alcock canal. So this figure is a very important short note. Write a short note on the lymphatic drainage of pelvis. So the lymphatic drainage of pelvis is, you have your, so in aorta, near the aorta you have your para-aortic nodes, and then at the level of bifurcation of aorta you have the node at bifurcation of aorta, para-aortic nodes, and then node at bifurcation of aorta. And then in the common iliac artery you have your common iliac nodes, and then common iliac artery divides into an external iliac and internal iliac. So you have your internal iliac nodes and your external iliac nodes. Okay, so from this internal iliac nodes will give various branches like obturator artery. So you have obturator nodes, and then you have your parametrial nodes, and then you have your sacral nodes. So all these are the lymph nodes of the pelvis that drain into the genital organ. Okay, so very very important lymphatic drainage. If they ask common iliac artery, the nodes will be corresponding to para aortic nodes. Okay, so aorta, you have your para aortic nodes, and then this aorta will be bifurcation of the aorta will be happening, So that is your common node at the bifurcation of aorta. Para-aortic nodes, node at the level of bifurcation of aorta, and then your common iliac nodes. From the common iliac nodes, you have your internal iliac nodes and external iliac nodes. From the internal iliac nodes will drain into the obturator nodes, all the obturator nodes, the parametrial nodes, and the sacral nodes. Very, very important. Obturator nodes, parametrial nodes, and sacral nodes. This is the lymphatic drainage. So if you see a brief about the lymph nodes draining the pelvic viscera, you have primary nodes and you have secondary nodes. So primary nodes, the vulva is going to be superficial inguinal nodes. Okay, vulva will be draining into the superficial inguinal nodes primarily and common iliac nodes secondarily. Whereas your lower vagina will be draining into the deep inguinal nodes primarily and external iliac nodes primarily and then para-aortic nodes secondarily. Your upper vagina will be draining into your external iliac nodes primarily and then common iliac nodes secondarily. And then cervix will be draining into your internal iliac nodes primarily, obturator nodes primarily, and sacral nodes. Internal iliac, obturator, and sacral nodes primarily, and para-aortic nodes secondarily. Then the uterus will be draining into your internal iliac nodes primarily, para-aortic nodes primarily, okay, and secondarily also para-aortic. So ovarian tube will be draining into para-aortic primarily, inguinal very rarely, and supraclavicular secondarily. So let's look at the key points of this chapter. The reproductive tract consists of external as well as your internal reproductive organs. The external reproductive organs include structures of vulva and the gynecological perineum. The clitoris is homologous to penis. The vaginal orifice is in the vestibule, lies between the two labia minora and partially covered by hymen. The Bartholin glands are located in the posterolateral aspect of the vaginal orifice and are not palpable unless enlarged. The muscles of the perineum are separated by the perineal membrane into the superficial as well as the deep muscles. Superficial muscles cause venous congestion, compression of the vestibular bulb and clitoris as well as erection of the clitoris. Deep perineal muscles are the sphincter urethra and deep transverse perineal muscles. They compress the urethra and support the lower vagina. So the axis of vagina is horizontal. The anterior wall is shorter than the posterior wall. Uterus is a pear shape with length of around 7 cm or 5 cm. 7 cm, that is 5 plus 2.5. Okay. Cervix is 2.5. Myometrium plays a major role in contraction of during parturition and contraction and retraction during delivery. The fallopian tube is 10 cm long. And the ligaments and supports of the uterus and vagina are formed by condensation of the endopelvic fascia. Cardinal ligament is the most important ligament and supports the upper vagina and supravaginal cervix. So important structures are ureter, descending artery, lymphatics and Frankenhauser plexus. The components of levator ani are pubococcygeus, iliococcygeus and puborectalis muscle. So lumbosacral trunk is from T12 to S5. So let's see some questions. A 45-year-old lady with diagnosis of cervical cancer is taken up for radical hysterectomy with pelvic lymphadenopathy. Due to prior laparotomy, there are adhesions in the pelvis. What are the points at which ureteric injury can occur? What are the primary and secondary nodes that will you remove? What are the structures in the cardinal ligament that you will encounter during dissection? The answer for the first question is at the pelvic brin, close to the infundibulopelvic ligament during node dissection, as it crosses the common iliac vessels till the broad ligament in the cardinal ligament of. So devascularization can occur where in the pelvis. So primary nodes are internal iliac, external iliac, obturator and sacral nodes. The secondary nodes are common iliacs and nodes at the aortic bifurcation. So ureter, descending cervical branch of the uterine artery and nerve plexus and lymph node are the contents of the cardinal ligaments. So the second question here, where 25-year-old lady comes with clinical features of acute pelvic inflammatory disease. So there is fullness of pouch of Douglas. What is the diagnosis? Pelvic abscess is the diagnosis. Clinical features of acute pelvic inflammatory disease, and it's going to be bogginess in the pouch of Douglas, which is a characteristic sign of pelvic abscess. The peritoneum on the posterior surface of the uterus extends down to the anterior surface of the rectum. This forms the cul-de-sac or the pouch of the Douglas. So this is the most dependent part of the pelvis, and the pus tends to collect in this pouch. Pouch of Douglas can be approached through the posterior fornix of the vagina. Okay, so the abscess is separated from the vaginal fornix only by vaginal wall and peritoneum. Course of the pelvic ureter is just studied now. Anatomical sites where it is susceptible to injury. Blood supply to the internal and external organs, genital organs. All of this, I think you know these questions. Thank you. So if you want to watch more videos on gynecology and everything, stay tuned, subscribe this channel, do like, share and click the bell icon. Thank you.